Hope you're all safe at home, completely isolating yourselves, not going out anywhere because the COVID is really taken a big part in our lives. So stay safe, stay home, and make best use of this time. I wish you all study well and get into the seats that you want to do in your post graduation in. Today, we will start with the Q&A session of developmental anomalies, and this will be the last session on Q&A. Okay, I mean developmental anomalies. After that, we will shift to another chapter. So let's begin with question and answer session of developmental anomalies. Okay. First question: which amongst the following is not a cause of acquired micrognathia? Can you answer this question? These are all from Neet papers. I didn't mention the year because some of which I got, some of which I didn't get the year of examination. But these are all Neet questions. So I would it will be good if you can answer these questions. Which amongst the following is not a cause of acquired micrognathia? Infection of the middle ear is one answer here, but the answer, see, the basic point for micrognathia is the jaw is not growing because there is some issue at the developmental site of mandible. The development site of mandible is mainly the TMJ area, right? So infection of mastoid definitely very close to TMJ, so definitely included as a cause for acquired micrognathia. Trauma to TMJ directly the reason for non-growth of mandible. Next is infection of the middle ear. Again, it is very close to TMJ, right? So the answer for this question is infection of the inner ear, which may not be the cause for acquired micrognathia. So the answer is D for this question. Hope you guys understood the question and answer, right? The answer is infection of the inner ear, slightly far from the TMJ, so that may not be the cause for the micrognathia in this situation. So let's go to the next question. Which amongst the following is not a clinical feature of micrognathia? Steep mandibular angle, severe protrusion of chin, prominent chin button, deficient chin button. Which do you think is not associated with micrognathia? Prominent chin button. Excellent answer. That is the right answer because rest everything goes with micrognathia except for prominent chin button. That can't be micrognathia, right? So C is the answer for this question. Excellent. Good. Let's go to the next one. Next is indicate the incorrect statement regarding macrognathia. So today it is a mashup of all the parts of developmental anomalies, most of which I could cover in 1 hour session. So all these jumbled questions you'll be getting from different parts of developmental anomalies. Okay. So here it is macrognathia. Indicate the incorrect statement regarding macrognathia. It is commonly associated with Paget's disease. Patients tend to have a short ramus. Excessive condylar growth predisposes to macrognathia. Patients have a prominent chin button. Now, this is just the reversal of that previous question. The answer is yes. If the B, yeah, B, most of you are all answering B, and that is the right answer. Patients tend to have short ramus, can't give rise to macrognathia. Macrognathia is a huge jaw, bigger jaw. So if you have a short ramus, it will lead to micrognathia. So that is the answer. So B is the answer for this question. Okay. Next is facial hemi atrophy is not associated with which of the following conditions? Bell's palsy, trigeminal neuralgia, Jacksonian epilepsy, delayed eruption of teeth, which is not associated with facial hemiatrophy. Do you know the syndrome for facial hemiatrophy? What is the name of the syndrome for this? The answer is Bell's palsy. Yes, the answer is right. It is Bell's palsy. Yeah. Perry-Romberg syndrome. Yes, this is called as Perry-Romberg syndrome, facial hemiatrophy. Right answer. It is progressive hemifacial atrophy. It is an uncommon degenerative condition characterized by atrophic changes affecting one side of the face. Okay, the possible causes for it are trophic malfunction of the cervical lymphatic nervous system and all that, trauma, also viral infection. So trigeminal neuralgia, Jacksonian epilepsy, all these are the cause for facial hemiatrophy. They are associated with facial hemiatrophy. Further, wherever the facial hemiatrophy is affected, in that region, teeth are delayed in erupting. Okay, so only answer is Bell's palsy, which is not associated with facial hemiatrophy. Okay, so that's the right answer. Next question is, cleft of the primary palate occurs anterior to incisive foramen, posterior to incisive foramen, between lateral incisor and canine, between canine and first premolar. I don't think we need to even read a lot of options for this question, but can you guys tell me which is the answer for this question? Primary palate is where primary palate is the area where you can see that the incisive foramen, anterior to incisive foramen is the area for is the area which is called as primary palate. Okay, so if cleft happens in the primary palate, it means it is happening anterior to incisive foramen. So A is the answer for this question. Okay, so let's stick to A because that is called as the primary palate, the anterior to incisive foramen. The other area behind that is called as the secondary palate. Here, just for your understanding, I have put an image here. This is the primary palate, and all this entire region is the secondary palate. So you should not have any confusion. Here is the incisive foramen. Anterior to it will be the primary palate, and if the cleft happens here, it is the cleft of the primary palate. Okay. Okay. So let's go. So answer is A for this. Next is, Hex disease is caused by dash virus. Which virus causes Hex disease? Any answers? Human papilloma virus. Answer B is given. Yeah, many of you are telling B, and that is the right answer. Hex disease is also called as focal epithelial hyperplasia, and the organism causing this disease, this kind of hyperplasia, what you can see an image. I have put an image to show the hex disease. You can see cobblestone appearance of the mucosa. Clinically, you can see it's called as cobblestone appearance. That is due to epithelial hyperplasia, multiple hyperplastic areas you see. Okay, as you see it in the lip, and it is caused by human papilloma virus, mostly the strain 3932. Okay, 3932 are the reason for the a virus that the strain or particular strain of human papilloma virus causing Hex disease. Okay, so next question. So the answer is B for this question. Next, Fordyce's granules is heterotopic collection of dash in oral cavity. This is again a straightforward question. There should not be any confusion. Is it sweat glands? Is it salivary glands? Or is it hair follicles or sebaceous glands? This we have been learning this from first BDS, and the answer is sebaceous glands. Yes, the answer is D, sebaceous glands. This is the ectopic collection of sebaceous glands in the oral mucosa, in the buccal mucosa, leading to what is called as Fordyce's granules. And this is 80% of the cases have Fordyce's granules, so it has become kind of a normalcy. Okay, it's considered as new normal. It is normal to the oral cavity. Fine. So that is the answer. Answer is D. Next, if a patient has multiple intestinal polyps, cutaneous melanotic macules, rectal prolapse, and gynecomastia, he or she is probably suffering from which syndrome? Is it Gardner syndrome, Coats-Gorlin syndrome, or is it Peutz-Jeghers syndrome or Greenspan syndrome? It is Seger syndrome. Whenever you see perioral melanotic macules and intestinal polyps, you can go for Peutz-Jeghers syndrome. That is most commonly the cause we have behind this, the symptoms of this syndrome. Next is Gardner syndrome. Gardner syndrome, what do we have? We have multiple supernumerary teeth, right? All those are the symptoms for Gardner syndrome. There is another question where I have explained the syndromes again. Then is Goltz-Gorlin syndrome. Don't confuse it with Gorlin-Goltz syndrome, which is basically associated with multiple odontogenic keratosis, basal cell carcinoma, etc. That is nevoid basal cell carcinoma syndrome is Gorlin-Goltz syndrome. This is Goltz-Gorlin syndrome. Okay, this of course is not again associated with this. Next is Peutz-Jeghers syndrome is the cause, showing all these symptoms is the Peutz-Jeghers syndrome. Greenspan syndrome again, the Greenspan syndrome, it has a triad of hypertension, diabetes mellitus, and what is that? Lichen planus. Okay, that is Greenspan syndrome. So these are the syndromes that you just should know the features of it a little bit. But the answer for this question is C, Peutz-Jeghers syndrome. Okay. Next is increased risk of development of squamous cell carcinoma is associated with which of the following developmental conditions? Is it cheilitis granulomatosa, Hex disease, cheilitis glandularis, or fibromatosis gingivae? It is C. Cheilitis glandularis is the answer for this question. Cheilitis glandularis is again an unusual clinical presentation of inflammatory lip, okay, which develops due to chronic irritation. Fine. Cheilitis glandularis is due to chronic irritation. It leads to progressive enlargement of the lip, which leads to eversion of the lip. Because of this eversion, it gets exposed to actinic rays, and hence there is chances of developing squamous cell carcinoma on the lips. So answer is C for this question. Okay, cheilitis glandularis. Next question. Sorry. Minimal form of clefting of palate is seen in soft palate, uvula, hard palate and soft palate, posterior to incisive foramen. Which you think is minimal form of clefting? We can have clefting of the entire palate from primary to secondary palate, either in the midline or on the unilaterally, okay, or bilaterally. So these are all severe forms of clefting. But if you want to say just very minimal clefting, which is not actually affecting the function, then it would be the clefting of the uvula, right? So the answer is B for this question. Minimal clefting is considered when the clefting is only in the uvula. Okay, next question. A well circumscribed soft sessile bilateral nodular mass which is located lingual to mandibular canines between mucogingival junction and free gingiva, it could most likely be peripheral giant cell granuloma, pyogenic granuloma, retrocuspid papilla, peripheral ossifying fibroma. Unanimously, you guys are saying retrocuspid papilla. Yes, that is the answer. We should keep that as the answer. Retrocuspid papilla is similar to giant cell fibroma, actually, histopathologically. Okay, it's a developmental lesion. Microscopically resembles giant cell fibroma. It occurs on the lingual side and the mandibular cuspid region. Okay, it is frequently bilateral and it is generally small pink in color, which is less than 5 millimeter in diameter. Okay, so this is about retrocuspid papilla. Next question. Fusion of teeth involves a confluence of enamel only, enamel and dentin, dentin only, and cementum only. Which is the answer for this? When we say fusion, when two teeth are fused together, we see fusion, confluence of enamel and dentin, or enamel only, or dentin only, cementum only. Yeah, there should not be any confusion. It can't be cementum because it is not concrescence. If it was concrescence, then we would call it as cementum, fusion by cementum, where again dentin will not be confluent. Okay, whereas fusion will, here we have the confluence of enamel and dentin both. That is why whoever has answered B as the answer, and that is the right answer. So B is the answer. Enamel and dentin are confluent in fusion of teeth. Okay, is that clear? Right. Next question. Apart from maxillary lateral incisor, which other tooth is commonly affected by microdontia? Again, this should be an easy answer. Yeah, if you have guys have answered D, I don't know if the recent answer is D. Yes, D is the answer. Third molar. Again, after lateral incisor, it is the third molar, which is mostly showing all these anomalies, developmental anomalies. Okay, for some reason these two teeth are quite affected by the developmental anomalies. Okay, so one second. So third molar. So D is the answer for this question. Okay, fine. Next. Staphne cyst or Staphne defect is an aberrant collection of dash gland tissue within a deep depression in the mandible. Which tissue? Sweat glands, sebaceous glands, mucous glands, salivary glands. What have got accumulated to cause this Staphne's defect? Is it? Okay. Yes. The answer is D. Again, no confusion from your guys. It is salivary gland. Salivary gland is there in the depression in the mandible, which is below the mandibular canal. Okay, in the posterior region. So that in radiograph affects us a radiolucency, and that is called as Staphne cyst or Staphne defect. It is just a finding actually. Okay, we cannot exactly call it as an anomaly, but it is a finding. It is just there and appears as an anomaly. That's it. Okay, and it is found in the radiograph. Okay, so this is the answer. So D is the answer for Staphne cyst. Excellent. Next question. Here is a clinical question. A nodular mass near base of tongue with presenting complaints of dyspnea, dysphagia, and without a demonstrable main thyroid gland could most probably be reactive lymphoid aggregate, lymphoid hematoma, lingual thyroid nodule, lymphoepithelial cyst. Again, this is another straightforward question, not much thinking required. Yes. Don't be hasty in answering. Okay, yeah, C is the right answer. By mistake some of have written D. Don't be confused. It is lingual thyroid nodule. It is a developmental anomaly which is seen in the posterior part of the tongue. Many a times it is small and of the same level as the tongue, but sometimes it will appear as a nodular big mass. In that case it will lead to dyspnea, dysphagia and all of that. We have to be very careful in treating this because you this may be the only thyroid gland in the patient's mouth, in the patient's body. So we have to make sure that the patient has a thyroid tissue and elsewhere, and then do the surgery or whatever is required to do the treatment. And generally the thyroid scan using technetium 99 is the scan that is done to test the thyroid gland. The diagnosis is done through that. Okay, so the answer is C for this question. Next is, amongst the following causes, the least probable cause of hairy tongue is smoking, poor oral hygiene, Epstein-Barr virus, radiation therapy. Which you think is the least probable cause for hairy tongue? Yes. Okay. There is conflict. D. Radiation therapy. C. Epstein-Barr virus. B. Poor oral hygiene. A. Smoking. Okay. The hairy tongue is basically because of hypertrophy of the filiform papilla, where keratin is forming in great quantity and turnover is poor. Okay, so that can happen in smoking, that can happen due to poor oral hygiene, and that definitely happens in patients with radiation therapy. But Epstein-Barr virus, it is not hairy tongue which it causes hairy leukoplakia. I think that is when the confusion starts, because Epstein-Barr virus is associated with something hairy, but it is not hairy tongue. It is hairy leukoplakia, which happens on the lateral border of the tongue. So C is the least probable cause for hairy tongue. Okay. Rest A, B, and D are quite common causes for hairy tongue. So the answer is C for this question. Okay. Is that clear? Okay. In immunosuppression also this hairy tongue happens. Okay. HIV cases and patients with immunosuppressive conditions or immunosuppressive drugs, you see hairy tongue. But Epstein-Barr virus is mostly associated with hairy leukoplakia. Okay. Next, histopathological features of benign migratory glossitis closely resemble that of lichen planus, B. psoriasis, C. systemic lupus erythematosus, D. erythema multiforme. Again, this should not be there should not be any confusion with this answer because we have discussed in great deal this particular lesion, benign migratory glossitis, which has no that it's we kind of call it as oral counterpart of psoriasis. So the answer is B. Excellent. Okay, majority of you have answered B. No confusion. It is B. Psoriasis because it has every other feature similar to the skin psoriasis. So this is the oral counterpart. You can say. Okay, psoriasis does not happen in the oral cavity, but benign migratory glossitis is the closest relative of psoriasis. Please remember that. So, what do we have in the psoriasis? The features are similar: hyperparakeratosis, spongiosis, acanthosis, elongation of the rete. You remember they are called as test tube shaped rete. They are all long and thin and extending into the connective tissue. Then there is collection of neutrophils in the epithelium. We call them as what abscess? Excellent. Monroe's micro abscesses, we see them in the epithelium, right? We all remember. The similar features are there in benign migratory glossitis, so they are relatives. Psoriasis and benign migratory glossitis are relatives. So the answer for this question is B. Okay, next. Median rhomboid glossitis occurs anterior to circumvallate papilla, posterior to circumvallate papillae, tip of the tongue, lateral border of the tongue. Again, there should not be any confusion with this question. This happens anterior to circumvallate papilla. Okay. I don't think we really need to because this happens on the midline, just close, very close, anteriorly close to the circumvallate papillae, right? Median rhomboid glossitis cause for this is initially it was thought to be failure of recession of what? What is why do we why the old school said that median rhomboid glossitis occurs due to during development of tongue, foramen cecum area, right? The first arch, yes, the foramen cecum area. If it fails to recede, it was thought to be leading to that glossy atrophic area called as median rhomboid glossitis. But now it is thought to be due to what? What is the cause for median rhomboid glossitis now? The latest thing is due to median rhomboid glossitis is associated with what etiologic factor which leads to kissing lesion on the palate. So what do you think is causing this median rhomboid glossitis in the first place, which is also you know infecting the palate, leading to the kissing lesion? Come on, guys. I think you should be able to answer this. No? This is a fungal lesion. Basically, now the new school says that median rhomboid glossitis is due to fungal infection because they have retrieved Candida albicans from that, and also antifungal therapy has improved the situation. Okay, so that is the reason the tongue when it touches the palate in the same region, similar rhomboid shaped lesion we see on the palate, that is called as kissing lesion. Okay, so this is about median rhomboid glossitis. Hope you remember the previous class discussions. Okay, next question. Which amongst the following is not a cause of macrognathia? Hemangioma, lymphangioma, Down syndrome, leukemia. Can I get some answers? I'm not sure if it is hanging or you guys have stopped answering. Can I get some answers? Which amongst the following is not a cause of macroglossia? Is it hemangioma? Is it, how do I, yes, lymphangioma, Down syndrome, or leukemia? The hemangioma vascular causes are the common causes for macroglossia. Also, Down syndrome is associated with laxed tongue, so it leads to macroglossia. So, the cause D, leukemia, is least likely cause for macroglossia. Okay, so that is the answer for this question. D is the answer. That is, leukemia is not a cause of macroglossia. Okay, let's go to the next one. Which one of the following is a synonym of fissured tongue? Is it lingua nigra, scrotal tongue, geographic tongue, or lingual varix? Yeah, I think there was some hanging, so I didn't get some of the responses. Now I'm getting it. Okay. Which one of the following is a synonym of fissured tongue? It is B, scrotal tongue. Excellent. Yes, scrotal tongue is the answer for this question. I don't think we need any more discussion on this because we have learned in great deal already. In association with which syndrome does talon cusp usually occur? These are all repetitions. So I think you should be able to quickly tell me the answer for this. Talon's cusp associated with, yes, A, Rubinstein-Tybee syndrome. Okay, Talon's cusp is nothing but dense evaginatus of the anterior tooth. You see that there is a well delineated cusp on the lingual portions of the anterior teeth, and this is very commonly associated with Rubinstein-Tybee syndrome. Okay, excellent. A is the answer for this question. Okay, with which variation in coronal morphology is dense evaginatus associated? Okay, this is an interesting question. You should be able to tell me this. This is peg-shaped laterals, shovel-shaped incisors, dilaceration, or distomolar. With which variation in coronal morphology the dense evaginatus, which is nothing but talon's cusp, is associated with? Okay. Yeah. If you guys have answered B, then it is the answer. That is shovel shaped incisors. Most commonly, the shovel shaped incisors will also show um, talon's cusp. Okay. So kind of the broadened crown with margins elevated, giving a very there is a shallow depression on the lingual surface with the talon's cusp, giving a that because of that shallow depression and elevated margins, it gives a shovel shaped to shape to the incisors. Okay, and with this feature, most commonly we have evaginatus association as well. Okay, so the answer is B for this question. Next, so please correct those who have answered differently. B is the answer. Next is dilated odontome is a synonym of dense invaginatus, talon cusp, dense evaginatus, macrodontia. Dilated odontome is nothing but, yes, dense indentate. Okay, dilated composite odontome. Sometimes the invagination goes inside and swells up, becomes big. That's when we call it as dilated odontome. Fine. So this is dense indente is nothing but dense invaginatus. So the answer is A for this question, and most of you have answered it correctly. Excellent. So dense invaginatus, which has two forms, right? A coronal and radicular portion. And you know that the entire dense invaginatus portion also has enamel lining, right? Right. Okay. Excellent. Next question is the base of invagination of crown or root in dense invaginatus contains, pardon the spelling errors, however, so the invagination of the crown or the root in the dense invaginatus contains what? The base contains what? Is it dystrophic dentin that is collected, or dystrophic enamel that is collected, necrotic pulp tissue, or dystrophic cementum. If you know the mechanism of invagination, you will know the answer. I just now told you the previous answer. I just told you, no, I just wanted to give you guys that hint so that you will be able to pick it up. So the inner enamel epithelium is kind of invaginating, right? So if that is invaginated, what do we get at the base of the, so inner liner is lined by what? What tissue? Is it dentin, enamel, pulp? What is it lined with? I'm sure you guys are answering, but I'm unable to see. Okay, I'm unable to see. I think it's gone in hanging again. I hope you guys have answered. Dystrophic enamel is the answer. B is the answer because the entire lining of the invagination is by the enamel. Okay, this is the answer is B. Dystrophic enamel is the answer for this question. Okay, hope you guys are answering that. Next question. I'm going to the next question. Which bone disorder should be considered for differential diagnosis in case of a finding of generalized hypercementosis? If you are saying generalized hypercementosis, which bone disorder you want to consider? Paget's disease, fibrous dysplasia, osteopetrosis, osteogenesis imperfecta. What is the answer for this question? Okay, I am okay. Good. Now I'm getting the answers. The answer is A. Paget's disease. Yes, most of you answered correctly. Paget's disease is the answer, where you see generalized hypercementosis of the teeth in the radiograph. You can see that every tooth has kind of showing the feature of hypercementosis. Okay, otherwise, there is this lesion. Paget's disease is characterized by anarchic resorption and deposition of the bone. Right. Uh, you see that mosaic pattern, right? Jigsaw puzzle pattern of the bone histologically. So all these are the Paget's disease features. So that please remember, hypercementosis, generalized hypercementosis is for somehow associated with Paget's disease, extensive hypercementosis. Okay. The answer is A for this question. Sorry. Okay. Paget's disease. Let's go to next one. If a patient shows signs of kinky hair, osteosclerosis at the base of the skull, brittle nails, along with hypomaturation and hypoplastic amelogenesis imperfecta, he or she is mostly suffering from, yes, it's suffering from, the answer is D. We have discussed this question before also. It is an autosomal dominant disorder, trichodento-osseous syndrome, and I had shown you the pictures of the syndrome also, right? In this, you also have hypoplastic type of amelogenesis imperfecta. So, trichodento syndrome, D is the answer. So, this question is coming repeatedly in the exam. So, be ready to face this question. Lack of development of 6 or more teeth is denoted by the term, yeah, denoted by the term, not anodontia. Anodontia is complete loss of teeth. Hypodontia is less number of teeth. Partial anodontia is again, few are there, few are not there. Okay, but there is specific requirement here, that is 6 or more teeth is denoted by the term. There is lack of development of 6 or more teeth only. It is called as, yes, oligodontia. Okay, again, this is again an autosomal dominant trait with incomplete penetrance leading to just few teeth missing. Okay, 6 or more teeth missing. So that is called as oligodontia. Most commonly missing teeth are maxillary, lateral incisors and third molars. Okay, so the oligodontia, A is the answer for this question. Fine. Next question. The appearance of normal thickness of enamel with extremely thin dentin and abnormally large pulp chamber, it is indicative of amelogenesis imperfecta, dentinogenesis imperfecta type 1, type 3, or dentin dysplasia type 2. Dentinogenesis C is dentinogenesis imperfecta type 3. Dentin dysplasia type 2 is D. So the answer is, yeah, please don't go by the error here. Dentinogenesis imperfecta type 3 with the large pulp chamber, which we also call as Brandywine type, also called as shell teeth. The teeth in this is shell teeth. So the answer is C for this question, dentinogenesis imperfecta type 3. Okay, type 3. Fine. Okay. Next question. Loss of organization of radicular dentin with subsequent shortening of root length is a feature of, yeah, this again can be a straightforward question. This you have learned. Dentin dysplasia type 1, dentin dysplasia type 2, dentinogenesis imperfecta type 2, dentinogenesis imperfecta type 3. Short root, shortening of the root length. Organization of the radicular dentin is disturbed. So dysplasia of the radicular dentin. So this has to be, please reply quickly. Again, I think it's hanging. The answer has to be A. That is dentin dysplasia type 1, which is the radicular type. Type 2 is the coronal type. Here very specifically they have mentioned the radicular dentin loss of organization. So the answer is dentin dysplasia type 1 because that is the radicular type of dentin dysplasia, and the teeth in this dentin dysplasia are called as rootless teeth. Okay, you know that. Fine. So the answer is A for this question. Next. Which amongst the following diseases is capable of producing developmental alterations in teeth? This is again a repeat question. So can you please answer this? Yes. Is it tetanus, chickenpox, diphtheria, syphilis? Syphilis. Unanimous answer is syphilis. That is right. Hutchinson's incisors, Mulberry molars, Moon's molars, Fournier's molars, all these are the teeth that we see with syphilis. So it can cause developmental alterations. So syphilis is the answer. Excellent. Let's go to the next question. Developmental anomaly of the tongue associated with fungal etiology. Okay, here we come. Geographic tongue, angloglossia, median rhomboid glossitis, wandering rash of tongue. The answer is, with fungal etiology, yes, median rhomboid glossitis. Yes, there may be repetition, but these will help you during writing exams. The trisomy of chromosome 18 is called, it is, yeah, there is a lot of repetition. Yes, trisomy of chromosome 18 is which syndrome? Mobius syndrome, Perry-Robins syndrome, Down syndrome, Edwards syndrome. Trisomy 18. It's not trisomy 21. If it was trisomy 21, it would be Down syndrome. Okay. Mobius syndrome. So we will just know what each syndrome is. Then maybe you'll be able to, tell me the answer. Okay, yeah, some of you are mentioning it as Edwards syndrome, and it is Edwards syndrome. Trisomy 18 is Edwards syndrome. It is also called as -5 syndrome because, or 5 minus syndrome it is called, because in this, the, on the chromosome 18, there is change of location. Okay, we will come to that later. Okay, next is, okay, fine. What is Mobius syndrome? It is basically the underdevelopment of cranial nerve, 6th and 7th cranial nerves. They are underdevelopment of these nerves. Along with that, we have, with this, we have the features of hypoplasia, micrognathia, retrognathia, the dental orodental features. So along with that, they have, clubbed feet, missing fingers, chest abnormalities, strabismus. All these are the features that you see in Mobius syndrome with corneal erosions as well. So if in case this such a question comes, you should know the features of this syndrome as well. So that is Mobius syndrome, which has anomal hypoplasia, micrognathia, and retrognathia. Okay, because of the corneal erosions, they may give the feature as in difficulty in blinking. Okay, if such a question comes, you should pick up Mobius syndrome. Whereas what happens in Perry-Robin syndrome? You know the Perry-Robin syndrome, right? Okay, we are lagging behind. Okay, Perry-Robin syndrome is basically, you know that, right? There is a small jaw, micrognathia of the and retrognathia of the lower jaw, leading to falling back of the tongue. Tongue should fall down because if the jaw space increases, the tongue will fall, and the palate will fuse. Right? That is what the sequence of events that should happen during development. But unfortunately, what happens because of the bad growth of the lower jaw, the tongue remains placed posteriorly, which obstructs the falling back of the palatal processes. Okay, so the palates won't fuse, leading to cleft palate, and tongue will remain, it will there because of it, and leading to the micrognathia. The micrognathia is there, then the cleft palate, and all these features are there. Because of the tongue falling back, you have airway obstruction as well. So these are called as Perry-Robin sequence. Okay, so the sequence of events that happen due to micrognathia, retrognathia. This is called as Perry-Robin sequence. So that is Perry-Robin syndrome. Next is Down syndrome, which is trisomy 21, the features of which you already know. Coming to Edwards syndrome, this Edwards syndrome is the trisomy 18, which is called by the doctor who described it. Okay, it goes by the doctor who described it. Here also the features are cleft palate, abnormalities of lungs, kidneys, and stomach, intestines, etc. There is deformed feet. It's called as rocker bottom feet. In Edwards syndrome, apart from remembering it as trisomy 18, please remember it is called as rocker bottom feet syndrome because the feet have a kind of a rocking chair appearance. They have that kind of surface. So that is Edwards syndrome. So just remember all these syndromes that will help you to answer few more questions in case they are twisted and asked. So the answer for this question is D, Edwards syndrome. Okay, excellent. Okay, next is cat cry is associated with which syndrome? Excellent. I have got a lot of answers for that. Yes, cat cry is associated with Down syndrome, DiGeorge syndrome, Cre-Du-Chat syndrome, none of the above. It is, yeah, Cre-Du-Chat syndrome is the answer for this question. Here, this is again it is this syndrome is called as 5p minus syndrome. Okay, not that the chromosome 5 is missing, part of the chromosome 5 is missing. Okay, the piece of it, so it is called as 5p minus syndrome. And here the infant in this condition cries in such a way that it sounds like a cat's cry. That's why it's called as cat cry disease or cry do chat syndrome. Okay, so the answer is C for this question. Next question. Next is triad of perioral pigmentation, bowel cancer, and breast cancer is seen in Trotter syndrome, Peutziger syndrome, Gardner syndrome, scleroderma. Triad of perioral pigmentation, bowel cancer, and breast cancer. The answer is Peutziger syndrome. Now, by now, you all know the features of Peutziger syndrome so well, which has mucocutaneous pigmentations. There are hematomonas polyps, intestinal polyps, okay, which can lead to bowel cancers. Then there is perioral pigmentation, okay. That is the answer. Scleroderma, of course, it is a progressive fibrosis. You know the other features of scleroderma, right? You please remember the coupe de saber appearance. There is a mark on the forehead because of the shrinking of tissues. So that's called as coupe de saber feature of scleroderma. It is progressive, and also remember that scleroderma is associated with Raynaud's phenomenon, right? Sorry, the crest syndrome, basically that entire all these calcinosis cutis, the Raynaud's phenomenon, esophageal dysmotility, all those features you must remember with scleroderma. So crest syndrome, if you know, sclerodactyly and telangiectasia, all these features. So just remember all these, which will help you again, as I mentioned, to answer some more questions. So if you know scleroderma, Crest syndrome should come to your mind. Reynolds phenomenon should come to your mind. Kubde-Saber should come to your mind. Gardner syndrome, when you think, you should remember the supernumerary teeth. Peutz-Jeghers syndrome, melanotic macules, and intestinal polyps, all the other features that we have been discussing. Okay, the Trotter syndrome is basically it's a cluster of symptoms with associated with nasopharyngeal carcinoma, which has other along with this carcinomatous features, you have trigeminal neuralgia because the carcinoma grows into the foramen ovale. Okay, so the nerves coming out of that will be injured, leading to trigeminal neuralgia and or soft palate immobility, etc., etc. Okay, leading to difficulty in opening the mouth. All these are the features in Trotter's syndrome, which is associated with nasopharyngeal carcinoma. If you want to write down quickly, jot it down so that you will be able to answer questions if questions are reversed and asked. Okay, fine. So, yes, chromosome number 5 is the other one. Okay, next. So, the answer you got it right. It is Peutz-Jeghers syndrome. B is the answer for this question. Next. All of the following statements are true concerning Peutz-Jeghers syndrome except transmitted as an autosomal dominant, multiple intestinal polyps, especially in the jejunum, variable melanin pigmentation usually present at birth. The tongue shows melanin pigmentation in most cases. Again, this is a very tricky question. So, what we have read and learned, all the clinical features, it's of course it's an autosomal dominant. It shows multiple intestinal polyps. It shows variable melanin pigmentation present at birth, but tongue showing melanin pigmentation is the one answer that is not there. So, except D is the answer for this question. Okay. Yes, D is the answer. Okay, let's go to the next question. Next is a patient 50-year-old lady complains of burning sensation of tongue on eating spicy food, which subsides on its own after some time. There are red and white lesions which appear as white lines with serpentinous borders lining around red lesion. Identify the condition. Such a big explanation for a very simple answer. Is it geographic tongue, erosive oral lichen planus, leukoplakia, atrophy candidiasis? It is geographic tongue because it has those serpentinous borders, multiple lesions, burning mouth syndrome it is associated with. It does cause burning mouth on eating spicy food. So it is geographic tongue. Okay, excellent. So A is the answer. Excellent. Next, patient complains of spacing in anterior teeth. On examination, the following appearance is seen. What is the diagnosis? See, this is an image based question. Okay, so this is the image that's given in the paper. Something similar, of course. Okay, so what will be your answer? Supernumerary tooth, odontoma, talon's cusp, toroodontism. Very clear question it is. It is a mesodens, which is a supernumerary tooth. So don't look for the answer mesodens. It has to be supernumerary tooth. A is the answer for this question. Next, mutation in Vanderwood syndrome is, this is again answer that you must know. You have to by heart such questions. There is no logic. I mean, you have to just remember these points. Is it mutation in IRF6 gene on chromosome 4 or mutation in IRF6 gene on chromosome 1, mutation of chromosome 6 or mutation of Philadelphia chromosome? The answer is chromosome 1. So the answer is B, mutation in IRF6 gene on chromosome 1. Okay, excellent. So that is the answer. The rest are to confuse you. So don't fall for those. Next. Okay. So these three questions which were, I had told, these are the last three questions that I have for today. These we had, I had shown you before, but there was some confusion with the responses, right? So that's why I brought these questions again. So that kind of completes developmental anomalies for this batch. Let's just discuss. See, what happens sometimes is the answer will be very simple, but because you are mentally blocked, you may not see the answer at all. Okay, so this is what happened with me and with you guys that day. I mean, dentinogenesis imperfecta is characterized by, we got a lot of responses, but kind of mind boggling it was, because there were so many choices and we went blank. Okay, so the answer choices were hypoplasia of dentin with normal enamel, hypoplasia of enamel and dentin, hypoplasia of dentin and enamel with normal pulp, bulbous crown with short root and obliteration of the pulp space. Okay, yeah, even that day, few of you were giving the answer as A, and A is the right answer. Just going back after the session, I found what happened. What happened? It was such a simple discussion because dentinogenesis imperfecta is a defect of dentate. Definitely the enamel is normal, right? So A has to be one option. Next is, it is not hypoplasia of enamel and dentin. It is not. So B is not out. It's out of the uh, you know option. Hypoplasia of dentin and enamel with normal pulp. Again, this is not an option because here again they are saying hypoplasia of both. So the last option is bulbous crown with short root and obliteration of the pulp space. Yes, dentinogenesis imperfecta does have these features. So A and D are the options. The A and D option is given by answer A. So the A is the answer for this question. Hope there is no confusion. Okay, I didn't want to leave you guys hanging. So A is the answer for this question. If at all it comes, please pick A as the answer. Next is, I also had told you this question. Amelogenesis imperfecta is a disorder of ectoderm, endoderm, mesodome, ecto and mesodome. It's definitely not endoderm and mesodome, but there was, ectoderm is the answer, definitely A. But I just wanted to check whether ecto and meso is kind of an option. It is not ectoderm because mesodome is healthy. Though there is interaction, ectoderm, uh, these are all solitary discrete lesions of those particular germ layers. So amelogenesis imperfecta is a disorder of ectoderm. A is the answer. Okay, then the last question. Fusion of teeth is more common in primary dentition, permanent dentition, mixed dentition, none of the above. Okay, again I wanted to touch upon this question because again the discussion kind of, yes, the answer is primary dentition, though most of the lesions are quite common in permanent dentition. Fusion is common in primary, again marginally. These are all epidemiological studies. There is definitely very marginal variation. Here it is 0.1% prevalence, and there it is 0.14%, the permanent, sorry, the primary one. So however, the answer for your exam, fusion of teeth more common in primary dentition. I hope I haven't left anything unanswered in all these sessions of my discussion for NEET preparation. If any doubt, any confusion, please bring us, connect through whatever way you can. We will be happy to answer all the questions. Okay, this kind of finishes our session today. Thank you for patient hearing and taking part actively. Very happy to meet you all. One request, please stay safe, be healthy, stay home, don't go out at all for whatever reason it is. Keep your family healthy and study well. All the best. Take care. Okay. Bye all.